All right, well, welcome everyone. Thank you for spending your Thursday morning with us. We have a very fantastic presentation today. My name is Lisa Naranjo, and I'm the Prevention and Early Intervention Program Supervisor here at Tri-City. Just want to go over a few housekeeping tips for everyone, and then I'll hand off to our next presenter. So just so you know, today we have the presentation scheduled from 11:30 to 1 o'clock. Dr. Felitti was speaking for about an hour, and then we'll do Q&A at the very end. So a lot of you, when you registered, you did already submit some questions, which we do have. But if you do want to ask a question during the presentation, please use the Q&A box that's on the very bottom of your screen. Just open that up, type in your question, and I will be on the back end during the presentation, either responding directly or tabling it for our Q&A session at the very end. We have a large group wanting to join us, so thank you for everyone who took the time to join us. If you have to jump off for other reasons, don't worry, this is being recorded and will be available in the future for us to review again. So don't worry if you have to jump off. I understand an hour and a half might be time constraints. So with that being said, I definitely just want to thank everyone who made the effort to make today happen for your time and energy. So thank you everyone on the back end, you know who you are. But I definitely want to introduce Tony Navarro, Tri-City's Executive Director, and so she's going to start with her welcome.
All right. Hello. Thank you, Lisa. Hello, Dr. Felitti. So good to see you again today and excited to have you. Hello, everyone. Thank you so much for joining us this morning, afternoon. We are Tri-City Mental Health. We are the mental health authority for the cities of Pomona, Claremont, and Laverne. And we are so excited to be bringing you this webinar today for a couple of different reasons. It was back in 2010 that I received a call from one of my best friends, Julie Gould. She's an LCSW, and we were former colleagues at an agency in the San Fernando Valley, where we worked with children and families who had experienced much trauma, whether it be individual, familial, or community violence and trauma. And we worked together for nearly a decade in that agency, and literally side by side. Our offices were right across the hall from each other. And when one day when she called me at Tri-City and she was teaching a course, she's now the CalSWIC coordinator and instructor at the School of Social Work at Cal State University Northridge. And she said, hey, have you heard about this? This is in 2010. Have you heard about this ACEs, this Adverse Childhood Experiences study? I'm teaching a class on trauma for students, and this is great information. She shared it with me, and immediately we began planning for her to come and train the entire Tri-City agency on adverse childhood experiences. And we have actually been bringing Julie out and training our staff every couple of years since 2010. In 2016, we realized that this is something we wanted to memorialize and have as a mandatory training for all of our staff. So before there was even an ACEs Aware initiative, she created a Train the Trainer curriculum. And we've been, Dr. Felitti, sharing your work and that of Dr. Nadine Burke-Harris, and training staff and helping families to understand the impact of their trauma on their current struggles, and also how to prevent the negative impact of adverse childhood experiences now for a very long time. So it is my great pleasure and honor. And hello, Julie Gould. I know you're out there today. And so Tri-City wants to thank you for your professional and guidance and your expertise in this. And Dr. Felitti, we are so thrilled to have you today. As many of you hopefully already know on the call, and if you don't, you're in for such a treat. We are here today with the co-principal investigator of the Adverse Childhood Experiences study. Dr. Vince Felitti has been an internist for over 50 years. He is a renowned physician and a researcher, and is one of the world's foremost experts on childhood trauma. He's the founder of the Department of Preventative Medicine for Kaiser Permanente, where he served as the chief of preventative medicine for over 25 years. Under Dr. Felitti's leadership, his department provided comprehensive medical evaluations to over 1 million individuals, becoming the largest single-site medical evaluation facility in the Western world. During this time, Dr. Felitti's revolutionary health risk abatement programs incorporated weight loss, smoking cessation, stress management, and a wide range of cutting-edge efforts to reduce patient risk factors. Dr. Felitti is also a clinical professor of medicine at the University of California and a fellow of the American College of Physicians. He's currently senior editor of the Permanente Journal and on the international editorial board of the Swiss medical journal Trauma and Gewalt. Dr. Felitti has also served on numerous advisory committees, including the Institute of Medicine, the American Psychiatric Association, Committee of Secretary, Health and Human Services for Healthy People 2020, and the Advisory Committee on Women's Services in SAMHSA. He's also a noted expert on genetic disease and hemochromatosis, as well as obesity. And he educates audiences around the country on these very two common and deadly maladies. So exciting to be able to chat with him live today, to hear from him live and be able to answer your questions. Thank you, Dr. Felitti, for joining us.
Well, thank you. I'm delighted to be here. What we'll be talking about, the Adverse Childhood Experiences study, is how we get from this newborn infant on the left with its extraordinary potential to the man lying unconscious on the sidewalk, whom we overlook out of fear. The implications of this are enormous because they relate directly and in unexpected ways to common, difficult problems in everyday medical practice and public health that we all are involved in. The findings of the ACE study have attracted attention literally around the world in unexpected places: school systems, police departments, judicial settings, state legislatures, and met significant amounts of resistance in medical practice and clinical practice. And my hope is that hearing what we found, you may be able to figure out how to make a change to that. Let me summarize our findings at the very start to give you some structure on the evidence that I'll start showing you in a moment. The ACE study is the largest retrospective and prospective 20-year prospective analysis ever done to examine the adult effects of 10 categories of adverse life experience in childhood. 17,500 adults were involved and followed over 20 years. The very existence of these experiences was unexpectedly high and overwhelmingly unrecognized, partly because they're lost in time, and partly because they're protected by shame and by secrecy and social taboos against routinely exploring certain realms of human experience. We've all been taught as children that nice people don't talk about certain things. And my God, surely don't ask questions about them. That's a problem to keep in mind. The effects of these unspoken childhood experiences a half a century later in adult medicine are powerfully and proportionately related to the number of underlying categories of adverse childhood experiences, not instances, but categories of adverse childhood experiences. And we found them to be a major determinant of adult well-being, health risks, biomedical disease, mental illness, job performance, social malfunction, and premature death. The study really began with this woman who showed up in 1985 in our new obesity program, asking if we could help her with her problem. Our first mistake was in accepting her diagnosis of what the problem was. And so we said yes and introduced her into the program. The program used a then totally new technology of supplemented absolute fasting, wherein people ate no food whatsoever for very long periods of time, up to a year. Now, if you do that, you have to take a special supplement that had recently been devised to keep from dying. Otherwise, as the Irish hunger strikers illustrated 10 or 20 years ago, you stop eating and drink water, only you die in about 6 weeks. And the reason you die is because of major potassium and magnesium deficiency, setting off lethal cardiac rhythm disturbances. Well, that's easy to fix. You just mix some potassium and magnesium in your water every morning, and that solves that. But then more complex problems start occurring further downstream. Anyway, the essence of it was we took her from 408 to 132 pounds in 51 weeks and naively thought we had this problem solved. Ultimately, she taught us that what is most obvious is not necessarily the essence of a diagnosis. And if I were to ask you which picture represents the patient's problem, I suspect you'd all pick the one on the left, the age 28. It really, she showed us that it was the picture on the 29 on the right that expressed the problem. And there's her picture at age 8, in case anyone would like, well, she must have been born fat, etc. Well, let's look into this more. Here's her weight graph. Looks like an Olympic ski jump. Zooms down from 408 to 132, stays there a few weeks. And then, in one 3-week period here, incredibly, regains 37 pounds. I didn't realize you could do that in 3 weeks, and ultimately got back to over 400 pounds in a shorter period of time than it took to lose the weight. And in pursuing what was going on, 37, what happened? How did that happen? She told me that she thought she was sleep eating. What do you mean? Well, when I was a kid, I used to be a sleepwalker, she said. I haven't done that for years, but I live alone. When I go to bed at night, everything's clean and put away in the kitchen. And I woke up in the morning and pots and dishes were dirty and boxes and cans were open. Somebody was obviously eating there. I was the only person there. I guess that's what was happening. Well, but why then? Why not 3 years earlier or 2 years later? Why then? And going down that path persistently, she shortly said, well, the day before the sleep eating began, she had been at work. She was a nurse's aide on a night shift at a convalescent hospital. And one of the workers there, a man much older than she made a point of, said to her that she looked really pretty good. She lost all that weight. And then, how about you and me making it every week, Patty? And that was the day the sleep eating began. And I remember thinking, well, it's a pretty crummy proposition, but I mean, this is 1985, it is Southern California. That's kind of an extreme response. Why the extreme response? And pursuing that ultimately led her to telling me how she had been molested repeatedly as a little girl by her grandfather from age 11 to 21. He had been having vaginal intercourse with her for over a decade. And suddenly even her job made sense. I mean, being a nurse's aide on the night shift, basically her job was to keep the old people in their beds. A couple of weeks later, another incest case came into the obesity program, came up, and we started routinely asking questions about childhood sexual abuse. And the response was extraordinary. It seemed every other person in the obesity program was acknowledging such a history. And I kept, I must be doing something wrong. People would know if something like this was going on. Someone would have told me in medical school. Wasn't that what it was for? Ultimately, in an 1,100 patient sample in the obesity program, we were seeing about 1,500 people a year in the program. In an 1,100 person sample, 55% of the adult obesity patients acknowledged a history of childhood sexual abuse. Absolutely mind-boggling. I presented our findings at a national obesity meeting in Atlanta in 1990. Was attacked by the audience. Some guy gets up and says that I really need to recognize that people like they, who have more experience with these things, he tells me, recognize that these statements by patients are fabrications to provide a cover explanation for failed lives. And I remember standing there in front of this huge audience thinking, do I tell this wretch what I think of him? Probably start a riot. The idea of claiming incest histories for social aggrandizement. I said nothing and the meeting ended. There was a dinner meeting for speakers that evening, and seated next to me was someone from the CDC, and he said to me, look, if what you're saying is true, it's got enormous importance for the country, as well as the practice of medicine. But nobody's going to believe your 286 cases, no matter how well you studied them. What we need is a large epidemiologically sound study with thousands of people in it, and from a general population, not some group you've somehow managed to accumulate. Okay, how many are we talking about? And we settled, 26,000, we can handle that. Because another division in my department provided uncommonly comprehensive medical evaluation to 55,000 adults a year in one setting. So we spent the next 2 years figuring out what we were going to do, how we were going to do it. People from the CDC came out to visit me to see if I really had what I was saying I had. And ultimately, in 1997, we presented our protocol to the Institutional Review Board, the IRB, that all medical research has to go through. And otherwise sensible people on the IRB said to me, that we could not proceed with the study. You cannot ask those questions. They're going to cause patients to decompensate, maybe occasionally become suicidal. You cannot proceed with this study. We spent the next 8 months battling with them before we got agreement. And this is the structure of the study, carried out in 2 waves, 13,000 people in each wave coming through for comprehensive medical evaluation, nothing to do with obesity, the general population. Clearly middle-class population, 74% had been to college, for instance, everybody with high-end medical insurance. And very comprehensive 2-visit medical evaluation, the dark box in the center here. Of the 26,000, we asked if they would help us understand more about how life experiences in childhood might affect adult health. 17,500 agreed. Oops. Sorry. And we then followed them for the next 20 years, matching what happened back here in the first 18 years of their life, comparing that to their current health status at age 57 on average, and then following them the next 20 years, matching all of this against pharmacy costs, ER visits, doctor office visits, hospital discharges, mortality, etc. It was a very, very big study. What we found was this. We picked the 10 categories of adverse childhood experiences study simply because they were the 10 most prevalent in our obesity program. And the question the CDC raised is, are these prevalent in the general population? Well, so they were these categories, and here are the prevalences in a general population. Major emotional abuse, basically recurrent humiliation by parents, 11%. Physical abuse, I'm talking heavy-duty beating, not spanking, 28%. Contact sexual abuse, Could be by anybody, but typically within the family, 22%, women 28%, men 16%. Major emotional neglect, 15%. Major physical neglect, 10%. Growing up in a home where there was an alcoholic or a drug user in the household, 27%. Losing a biological parent for any reason, divorce, death, suicide, before the age of 18, 23%. Growing up in a home where one of the members of your household was chronically depressed, mentally ill, or in a state hospital, 17%. Growing up in a home where mother was treated violently, 13%. And the 10th category, growing up in a home where one of the members of your household during childhood was imprisoned, 5%. These are extraordinary levels. On the other hand, you have to routinely ask questions that none of us ask to get this information. The population in the ACE study, by the way, 80% white, including Hispanic, 10% Black, 10% Asian, everybody with high-end medical insurance. And as I mentioned before, 74% had been to college, and everyone, well, I mentioned everyone with high-end medical insurance. We were dealing with mountains of information, and we needed some way of simplifying it. So we created an ACE score, which was the number of categories, not instances, but the number of categories was summed. In other words, if somebody was molested, 32 times or whatever, that was simply 1 point for the category. And the reason we did it that way was because it was obvious that this uncomfortable information would otherwise quickly be attacked. Come on, you're trying to tell me that somebody remembers a half century later that they were molested 13 times as opposed to 17 times or what have you. So ACE score 0, none of the 10 categories, 33% acknowledge that. ACE score 5 or more, 11%, 1 in 9 people. What that means from a medical standpoint is that basically any physician in the country is going to be seeing 2, maybe 3 ACE score 5 patients every day, ACE score 5 or higher patients every day. And overwhelmingly, they will not be recognized. We also found that women were 50% more likely than men to have an ACE score of 5 or higher. Here's our patient. Here's our patient who quickly regained all of her weight, disappeared for a year. She then unwisely decided to have bariatric surgery without dealing with any of the underlying issues. And at a point where she had lost only 95 pounds from the bariatric surgery, which was not clearly visible by reduction in size, she became intractably suicidal, required 3 courses of electroshock and 5 psychiatric hospitalizations in 1 year. And here she explains why this happened. And she helped us begin to see that what may be viewed in public health as the problem may be viewed by the patient as a solution to problems that were never identified. And mistaking somebody's solution for their problem is a serious mistake that we commonly make. And it's a big piece of what makes preventive medicine and public health so difficult. So let's listen to what she has to say about the major threat that weight loss produced in her.
I wasn't really handling the weight loss too well. I mean, it came off too quick, and I just felt like I was losing my protective wall. It was like, you were right, there was no going back. I wasn't able to use food as my way to get fat again, to have my solution back. It's like I had lost my solution, and I was having a hard time trying to find other solutions to deal with the underlying issues of obesity versus just using the obesity as my wall.
So she's making a major point there that what we see as the problem, she saw as a solution to problems that we know nothing about. Example, I remember years ago talking with a woman in the obesity program, going through her life year by year, what she weighed. We get to age 23, she tells me she was raped, and in the year subsequent gained 105 pounds, and looks down at the carpet and mutters to herself, overweight is overlooked, and that's the way I need to be. Keep the concept in mind, because it plays out in innumerable ways other than obesity. Here's her sister. Obesity runs in the family. So too does speaking English. It's important not to conclude that because something is familial, it means genetic. It doesn't. What's the heaviest you've ever been in your life?
In excess of 400.
So the same as your sister Patty?
Yes.
Uh-huh. And how and why did you get so fat?
Well, I was abused sexually by my uncle. And once again, I used food as a comfort. I didn't have much of a childhood because I started working when I was 13. Then I got married at 17 to get away.
How old were you when your parents got divorced?
I recall I was 9.
Did you ever see your father again?
No.
How do you think being abandoned by him affected you in the rest of your life?
It affected me a lot, especially with the growing up years, because like there was father-daughter dances and dinners, and I'd have to take an uncle and, you know, things like this. Everybody else would talk about their fathers and mine wasn't around. And it was devastating when my mom and dad broke up. I remember very distinctly.
In terms of childhood onset obesity, parental loss, particularly by divorce, is of enormous importance. But it's an untouched topic, so most people are not aware of that. Here's a man's view of things. He has some very insightful things to say about the functionality of some common addictions that we view as dysfunctional. His childhood was that his parents divorced when he was 3. He never saw his father again. Mother remarried at 5, and around age 6, for unclear reasons, his stepfather started beating him every day. He tells me he remembers one day walking to school, the thought crossed his mind, nobody is ever going to be there for me in my life. He became a very heavy smoker, a very heavy drinker, and a drug user. One day when he's 20, he comes home to visit and finds his stepfather beating his mother. Impressively, he takes a heavy cast iron frying pan and fractures his skull, and additionally produces 3 long bone fractures He's imprisoned in Rhode Island for a number of years for attempted murder, gets out, becomes a good citizen. Listen to what he has to say about all of this, about the functionality of what we commonly misdescribe as dysfunctional behavior.
20 to 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Got rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
In keeping the door closed to
The memories that I've blocked out with all these years with the alcohol and the drugs.
so you see what's happening to you now as related to what happened to you decades ago.
Yep. I found a way to block the emotions and the memories.
With
Drugs, alcohol, cigarettes.
Although it's been known for about a century, most people are not aware that nicotine has powerful psychoactive benefits. It is a strong anti-anxiety agent. Those benefits come on within 15 or 20 seconds of inhalation. The risks are certainly real, but they're 15 or 20 years away. Alcohol, well, think of the common statement, sit down, have a drink, relax. Well, some people need a lot of relaxation. It's hard to get enough of something when it almost works. Street drugs, well, we'll look at that in a moment. So addiction is the unconscious compulsive use of psychoactive materials or agents. And as we had painted on the wall in our obesity program building, it's hard to get enough of something that almost works. The conventional concept is that addiction is due to characteristics intrinsic in the molecular structure of some substance. I used to believe that. Sounds pretty reasonable, pretty scientific. Supposedly if you take heroin enough times, you can't stop, etc. What we found instead was that addiction highly correlates with characteristics that are intrinsic to that individual's childhood experiences. Let's look at nicotine. Look at the relationship between ACE score and the likelihood of being a heavy smoker as an adult. As the ACE score goes up, the probability of being a heavy smoker goes up proportionately. Smoking helps, but it's bad for you. Yes, it is. Opposing forces are routine in nature. It helps immediately and the risks are in the future, but I need help now. Look at the relationship of underlying ACE score to self-acknowledged alcoholism. This is really rather dramatic. May understate the case a bit because this is self-acknowledged alcoholism, and undoubtedly some people chose not to acknowledge that. Again, the benefits are immediate when they're needed. The risks are far in the future. Look here at injection drug use, street drug use. Again, as ACE score goes up, you see a very dose-responsive relationship to the outcome of IV drug use. At ACE score 6 or more, the response is so extreme that it doesn't really fit on the graph without compressing the rest of the graph into illegibility. At ACE score 6 or higher, the likelihood of that individual becoming an injection drug user is 4,600% greater than it is for an ACE score 0 individual. And I remember people at the CDC telling me that numbers of that magnitude they see once in a career. In America, our most common street drug is crystal meth, methamphetamine. Not many people know that the very first successful prescription antidepressant introduced for sale in the early 1940s was methamphetamine. Does that mean anything? That our most common street drug is an acknowledged potent antidepressant? But isn't it dangerous? Yeah, well, but no more so than, if you don't understand dosage, no more so than aspirin. I mean, if you take 30 aspirins, you've taken a suicidal dose. You decide to triple your digitalis dose to see if you can't get a better effect from it. You'll be dead in about 10 days. So does this matter to our treatment of any of the addictions? Do you think we should focus on the underlying cause? Or do we continue providing vacuous advice that what's being done is bad? Or as Mrs. Reagan once commented, just say no, especially when we see that that approach doesn't work. So keep this picture in mind. This is a full-page advertisement from the Journal of the American Medical Association in 1943 for the then highly successful new prescription antidepressant, methamphetamine. Is there a story here? So what we found, what we were discovering was that what are conventionally viewed as public health problems often represent a patient's attempted solution to long concealed adverse childhood experiences. Here's a woman who has something really important to say. She was heavily molested as a child. She treated that with 3-pack-a-day smoking, and she was thin. She married at 17 to escape her family. And when she was 35, weighing 130 pounds, her husband convinced her to stop smoking for her health. She did. And when she did, she suddenly started attracting male sexual attention, which she had no experience with handling because, as she explained to me, when you smoke 3 packs a day, the cloud around you keeps people at a certain distance. So this sexual attention that she was attracting was quite frightening, and she ate to ease her anxiety. And she quickly gained from 130 to 310 pounds. That certainly solved the male sexual attention problem, but it made manifest the significant lung damage that she had suffered, but which she was able to tolerate when she weighed only 130 pounds. So she had to go on 24-hour-a-day oxygen. Some years later, when she came into our obesity program, before we fully understood obesity, she entered the program and we took her from 310 to 150 pounds, and she no longer needed the oxygen. And we were very pleased with our great success, but it caused the resumption of male sexual attention, which was again very threatening. And she consciously made the decision to regain the weight and accept the fact that she would use 24-hour-a-day oxygen the rest of her life. Listen to what she has to say here. You supplied me recently a lengthy
autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. Took us a long time to figure that out here. You just casually drop that as though, of course, anyone knows that. So you are in respiratory failure on 24-hour-a-day oxygen.
Yes,
Major amounts of weight, overweight.
yes,
And you demonstrated, or we demonstrated together a couple of years ago, that when you had a major weight loss in the OptiFast program here, that your need for oxygen disappeared.
that's correct.
So that, if you lost 150 pounds approximately, the need for oxygen would no longer be there. The weight came back. Most people have very little understanding of why people get fat or regain. I mean, they're stuck with the simple belief, don't you know it's bad for you, etc.
We'll stop there. She goes on at some length and says a lot of important things, but the essence that I wanted you to hear was her comment that weighing 300 pounds and smoking 3 packs a day were not the problem. They were the symptoms of the problem. A really, truly profound insight. Minutes later, she began talking about her chronic depression. When we looked at the relationship of adult chronic depression to underlying A score, we saw a very clear relationship. Here it's depicted red for women, yellow for men. We looked at the relationship to suicide attempts. Very clear. Once again, A score 6 is not depicted because at A score 6 or higher, there's between a 3,100 to a 5,000% increase in the likelihood of attempting suicide as compared to an A score 0 individual. But once again, putting that on the graph dwarfs these data into obscurity and hence is not done. We look at prescription antidepressants a half century later. Relationship of receiving prescription antidepressants to underlying A score, once again, rather dramatic in a so-called dose response relationship. We looked at high-level promiscuity, which we defined as having 50 or more, 50 or more lifetime sexual partners. Here you see, again, a relationship to underlying A score. And this information might be better titled Looking for Love. Well, maybe the next woman or the next man is the one who's going to love me, and if not that one, well, surely the one after that. And sometimes when relating to one's peers is too threatening, that hope will be fulfilled by a child or by photographs or by a farm animal. We looked at hallucinatory activity. So here you see a relationship to the making of madness. What you see is that as the A score goes up, the likelihood of having hallucinatory activity goes up, so that at A score 7 or higher, the likelihood of hallucinatory activity is about 9%. Of course, to find that out, you have to ask everybody, and most people would never know that and hence don't know that. We have two colored graphs here, one for people who abused alcohol or drugs and the other for those who didn't. And the reason we did that was because we felt that there would be those who tried to make this go away by saying, yeah, well, I mean, the reason that they're hallucinating is because they're using so much alcohol or so much drugs. But when you correct for that and look only at people who don't use alcohol or drugs in the pale bars, you see basically the same relationship. And here we look at job performance. Toxic environments are real enough at some work sites, but not nearly as common as toxic childhoods. So here we see the relationship underlying a score to absenteeism, to self-acknowledged serious financial problems, and to having serious problems performing one's job properly. This is rather interesting in the middle because it makes the point that we really should consider poverty not as a basic cause, but rather as the outcome of other more basic causes. In other words, poverty is not a primary cause. It's a manifestation of other underlying problems. Here we see that unintended pregnancy, usually written off as an accident, is not totally accidental. And we also found that miscarriage turned out to be proportionately related to A-score. And that moves us into the biomedical mode. How could miscarriage be related to distant childhood adversity? Keep that in mind as we look at other biomedical issues. We looked at heart disease. The conventional Framingham risk factors for heart disease, like smoking, cholesterol, diabetes, etc., obesity, don't explain the 12% of people with heart disease who don't have any of the Framingham risk factors. When we looked at them, what we saw was that there was a distinct relationship to underlying A-score. How does that work? If they don't have the conventional risk factors, how do they get heart disease? Well, here's the rest of the story, and this is new information really developing in the past 1 or 2 decades. Toxic stress, in other words, stress that is chronic over time. Toxic stress chronically hyperstimulates certain areas of the brain, the hypothalamic pituitary adrenal axis, and leads to the release of pro-inflammatory chemicals that cause inflammation in the lining of arterial blood vessels. Once the lining of blood vessels becomes inflamed, it has a magnetic effect on cholesterol as it flows by, regardless of whether it's high levels or low levels of cholesterol. Pulls it out of the blood and precipitates it, causing obstructing cholesterol plaques. To help keep that idea in mind, you should know that in recent years, it's been found that the major effect of statins is not their cholesterol effect, their cholesterol lowering effect. They do that, and that's useful. But their main effect is not that. Their main effect is the anti-inflammatory effect they have on the lining of blood vessels. Really an impressive surprise. Here's a woman who looks like she's doing quite well, but she's got serious problems that are masked by intelligence and by dressing nicely and speaking well. She has a position of responsibility in a major university. We might never think of asking her these ugly childhood questions because she's obviously doing so well. So because of that, because of the fact that people don't inquire, she wants us to know the reality of her life. And she wants her name on the slide because she doesn't want what she has to say reduced by anonymity. Let's listen to what she has to say.
Can you tell just by looking at me that I was an abused child? Can you tell that I was sexually abused routinely, that I was neglected, starved, beaten? Probably not. You would have to ask in order to find out, and that's not the sort of thing that people typically ask about. The downside of having this kind of childhood is that it translates into health problems in adulthood, at least in my situation, it seems to have done. I'm now recovering from my third battle with cancer. Not the same cancer, 3 different kinds of cancer. I've had chronic pelvic pain, migraines, the whole laundry list of medical complaints, all of those sorts of things that are very difficult for physicians to figure out. Growing up that way instills a constant fear, a constant state of turmoil that's just under the surface of a veneer that's fairly thin. Little things become scary in an atmosphere like that. And once you've internalized all of that, it's very difficult to let go of it.
We'll talk more about the cancers in a moment, but first we should go back a moment to what we were talking about, cholesterol and it being precipitated out by inflamed arterial linings. Unfortunately, she died of coronary disease in her 40s, having none of the conventional risk factors for heart disease.
Can you tell just by...
We should say something about resilience because it would be easy to mistake people as being resilient because they're doing well occupationally or academically, etc., or financially. This is an extraordinary autobiography. You can sample it on Amazon. It's the remarkably open and frank autobiography of a United States federal judge. She was extensively molested as a child by her father. Worse yet, he used to bring her into saloons at night and sell her to strangers for sex. Somehow she did not commit suicide or become a mass murderer. She graduated high school, got into college, graduated into law school, became a law school professor, ultimately a United States federal judge. It would be very easy to say, isn't it wonderful that that little girl with that terrible, terrible history was so resilient? One of the major researchers in the field of resilience, a woman named Emmy Werner, mentions on page 67 of her book the importance of looking at biomedical outcomes when we're assessing resilience. Judge Bullock has had 5 different kinds of cancer, not relapses, different kinds of cancer. And in addition, 3 autoimmune diseases. She has lupus, multiple sclerosis, and rheumatoid arthritis. And in the A study, we looked at 21 different kinds of autoimmune disease and saw a distinct dose-response relationship of 16 of them to underlying A score. So this plays out in remarkably unexpected ways. We could summarize how you get from adverse childhood experiences to biomedical disease. First would be through the side effects of various coping mechanisms: heavy smoking, heavy drinking, obesity, etc., as we saw earlier. Second, by complex central nervous system hyperstimulation, as we just have been talking about, how toxic stress hyperstimulates certain areas of the brain to cause, in the case of cancer, immune system suppression. Oh, I should mention something there. Pretty much everybody knows that if you get an organ transplant, you need to be on lifetime immunosuppression so you don't reject the organ. Some people will correctly have heard that one of the side effects of lifetime immune system suppression is an increased risk of cancer. That's because all of us are forming every day small numbers of cancer cells from a wide variety of different organs in our bodies. Our immune systems recognize them, destroy them, and we never know that that's going on. But in people who have their immune systems suppressed by the hyperstimulation of toxic stress, then that destruction does not occur and they proceed to overt malignancy. And there's a third category, epigenetic effects. The word barely existed when we were planning the A study, so we did not study epigenetic effects. The term refers to the effects of environmental stimuli on gene function, not on gene structure, that would be a mutation, but on gene function, essentially putting an on-off switch on the gene. The field has grown explosively, and you'll be reading a lot about it in upcoming years. So let me remind you of this public health paradox that we found, that nice people don't talk about certain things, and these are generally unrecognized. But many of our most common and intractable public health problems are the result of unconsciously attempted solutions to personal problems dating back to childhood that are lost in time and further concealed by shame and by secrecy and by social taboos against discussing certain topics. So our lifelong inexperience in speaking about certain topics leaves us clumsy and embarrassing ourselves when we try to do so in clinical settings. What we found is that to increase the likelihood of getting critically important information like this, that information should initially be collected by an inert mechanism like a well-devised comprehensive questionnaire, and then discussed face-to-face. Let me show you what I mean. Here are some excerpts from a 10-page medical history questionnaire that everyone in our department had to fill out as step 1 of comprehensive medical evaluation. Questions like these: depression, nervousness, drinking, street drugs, raped, sexually molested, etc., physically abused, and so on. This is a very important idea. This was a piece of a 10-page medical history questionnaire. We then collected that questionnaire, passed it through a digital scanner that picked up all of the yes answers, gave us a nice 2-3-page laser printout. Here's a sample of an actual one. Here's a woman who has, who has not been sexually active, was physically abused as a child, was verbally abused as a child, was sexually molested as a child or adolescent, etc. She says she's having serious problems with her family, with her job, with finances, problems controlling her anger and sticking up for herself. Well, what do you do with this information? Well, that's an important question. And here's what we did with it. We would say to a patient in the exam room, I see on the questionnaire that. Can you tell me how that's affected you later in your life? And we listened, period. No humbug about, oh, I'm so sorry to hear that. That must have been awful. We listened, period. In other words, I see on the questionnaire that you were the one who discovered your father's body when he hanged himself. How did that affect you later in your life? I see on the questionnaire that you were raped and molested as a child. Can you tell me how that's affected you later in your life? And we listened. This had major effects that we'll come to shortly. But these things are very difficult to deal with after the fact. And so this picture will provide some insight into the difficulty. This is a PET scan, which depicts biochemical activity here in the brain. On the left, a normal American child. On the right, a child who grew up in the profound isolation of a Romanian orphanage in the Ceausescu regime about 20 years ago. And what you see is large areas on the right where there is no color, no biochemical activity. In other words, what we're looking at is the depiction of life experiences in childhood, or lack of life experiences in childhood, translating into neuroanatomy. And that has a great deal to do with why these things are so difficult to deal with after the fact. I'll summarize what we learned in the ACE study. Mainly that adverse childhood experiences are common and they typically affect adult job performance, disability, and social malfunction, well-being, depression, earnings, obesity, smoking, alcoholism, drug use. Big effect on biomedical disease and life expectancy. At ACE score 6, for instance, we found that life expectancy on average was shortened by 19 years. Big effect on medical care costs and on subsequent generations. You could summarize that this way. Large base of adverse childhood experiences, overwhelmingly unrecognized, producing disruptions in brain development, which in turn produce impairments in social, emotional, and learning abilities, which in turn cause people to adopt behaviors that are immediately helpful but often destructive in the long term, leading to disease, disability, and social problems leading to early death. Adverse childhood experiences are common and typically unrecognized. Their link to major problems later in life is strong, proportionate, and makes sense. They are the nation's most basic public health problem. It's comforting to mistake intermediary mechanism for basic cause. Oh, the reason the kid's fat is because the damn McDonald's is in town. No, that's an intermediary mechanism, not a basic cause. Well, the reason he's depressed is because he's got some neurochemical changes in his brain. Once again, no, that's true. The neurochemical changes are there, but they're an intermediary mechanism, not a basic cause. We saw that what presents as the problem may be somebody's attempted solution. Oh my. And that unwittingly treating their solution or attempting to treat their solution may be threatening and cause them to flee treatment. And that primary prevention is presently the only feasible population approach. We don't know how to do that yet, but it's the thing to keep in mind. How would you prevent this in the first place? I believe if we could figure out how to improve parenting skills across the nation, that might be the most major public health advance of our time. And lastly, I should point out that the things we're talking about have been resisted significantly in spite of potentially enormous benefits. Here's what we learned, just the beginning of turning research into practice. We found that set up properly and in high volume, a comprehensive medical evaluation can be affordably provided to all patients at the outset of ongoing medical care. We learned that comprehensive biomedical evaluation provided a net 11% reduction in doctor office visits in the next year, but that a comprehensive biopsychosocial evaluation that incorporated the ACE study questions led to a 35% reduction in doctor office visits in the next year compared to the prior year. That was a 135,000 patient sample, 2.5 years throughput for our department. It is that and the huge economic implications of that are in the multi-billion-dollar range that are what has attracted the attention of 23 state legislatures, now most recently California, with their ACEs Aware activity. So progress is occurring, but it is painfully slow. If you want further information, just going onto the internet or YouTube and typing in adverse childhood experiences study will provide a deluge of citations. And if you have some specific question, like adverse childhood experiences study and suicide, just put -suicide after adverse childhood experiences study, and you will find information precisely located related to your specific interest. Look at www.acesconnection.com, a superb daily blog that you can connect to at no charge. Wonderful source of information. CDC website here, an organization called AVA Health has put out a detailed 4-hour DVD on the ACE findings. Nadine Burke-Harris, the new Surgeon General of California, has written a very popular book, very good book called The Deepest Well. Or if you have specific questions, you can email me at this address. Well, we'll stop there, and we have some time now to address any questions that you may have.
Oh, thank you, Dr. Felitti. That was every time I hear you speak or watch a new video that has come out, a new presentation, I've learned something new and I take away something more. So thank you so much. I know that we do have some questions, and I'll turn it over to Lisa Naranjo to field those for us.
Yes, thank you. So we have 2 questions right now in our Q&A box that we'll start with, and then I have more from the registration list. So the first one asked, I was wondering if there is research that conveys the relationships between ACEs score and childhood experiences on people of color. So I don't know if Dr. Felitti or Tony wants to.
There may well be. We did not segregate it out that way. As I say, 10% of our population was a Black population in the ACE study. You might simply look that up on the internet. Adverse childhood experiences study, racial, just what would be the right word? Racial findings. That might be a good starting point.
Yeah. I am aware, I heard a podcast over the summer. There's a researcher out of, I think, Michigan, who is a Black psychologist, and he's doing some research on that and delving into that. So there might be some as you said, findings that you can go to, or at least discussions about it on the internet. Lisa, I think there was a question that came in earlier too, from Amanda before that one. Yeah, okay.
Yeah, I answered that to her directly, but she was asking about trainings. If we're
no, it was the one around, is this Dr. Felitti, and I think you and I had a conversation about it. So I'm sure there are people on the call who are interested as well. We talked about, is this being taught in medical school? Is the ACEs study part of the standard, medical training? We hear a lot about it in behavioral health, and just wondering, and I know you had some thoughts about why it's taken so long for the medical field to pick this up.
It's beginning in some schools. For instance, every year, I speak at the University of California in San Diego Medical School about the ACE study. It is very well received by the students. As a matter of fact, I've had a number of times the interesting experience of being stopped walking across the campus by some student who heard me speak a couple of years earlier and wants to thank me for that presentation. So it's very well accepted by medical students. I think that's an important start.
Yes, and I think what you had shared earlier is that in the past, it was difficult for doctors in different specializations. They saw this more before there was such comprehensive research as a psychiatrist's questionnaire, as something that psychiatrists should be addressing, not physical health providers. And with all the extensive research and findings that are coming out now, we are seeing change in that. And as you said, it sounds like the younger doctors coming in through medical school are really excited to get this information and put it into practice.
And an important piece of background information there. In all of medicine, there are only 3 sources of diagnostic information: patient history, physical examination, and laboratory studies. If you ask patients, and I've literally done this of 10,000 by questionnaire some years ago, at the 95% level, they overwhelmingly assume the diagnosis comes out of lab tests. Oh, I want all the blood tests, doctor. Yeah, you don't have enough blood in your body for all of the blood tests. If you ask experienced physicians, they'll tell you that about 70% of the time diagnosis comes out of patient history. It may be confirmed by physical findings or by laboratory studies, but out of patient history. An important piece of information there is that when dealing with complex subjects, it's important to explore all aspects of the subject, not just the manifest problem. Good example, a house burning down. The manifest problem is the smoke billowing out. Oh my God, you know, people can die from smoke inhalation. We better bring big fans to treat those house fires and keep people safe. Fortunately, fire departments understand that you look for the piece that is underlying causally, the piece hidden away, the fire inside, and bring fire hoses, water hoses to treat that. So the problem with really comprehensive medical history is that it's very time consuming. Hence the importance of collecting it by an inert mechanism initially, as we did on a huge scale, 10-page questionnaire filled out at home. Probably better yet, still put on the internet, that anyone could fill that out at home at no charge. And if they wished, provide that information to their physician, who then would have a very clear idea of where they need to go further and where they don't need to go further.
Thank you. Just to stay on track, there was a question, and I don't know, this might be a lengthy answer as well, but someone put in, what about when a mother who is overweight and she is giving same food as she eats to her child, and her child, who's 9, is obese as well? Mom is doing that to help her child because of her trauma of sexual abuse. How can we help mom stop overfeeding the child to have the same health issues?
You raise a good point. And it would really probably be the most sensible approach to try to understand why the mother became obese. And the best way of starting with that, how old were you when you first began putting on weight? Because whatever the cause was had to be then or before. So that narrows it down a great deal. And then work on helping her, which would then secondarily help the child.
Thank you.
Yeah, I think that really speaks to, and that was one of the things that I flagged for myself as well, Lisa, and really sharing with our agency is that is why it's imperative that as child and adolescent providers, we include the family and the parent from the beginning, and that we also establish really close collaborative ties with adult providers. If you're not an agency that sees the full spectrum of patients from childhood through to older adult, it's important to have a close collaboration with an agency that has the population you don't. Because certainly in order to really help that child, we're going to need to get the mom her own help and then have them work on it together.
Thank you. I know California is taking a bold initiative, hence the ACEs Aware initiative for statewide screening for ACEs. But someone asked, what are recommendations for national policies that would allow the progress around the country, not just in California? Any recommendations?
Well, two ideas haunt me. One is the idea of developing a really comprehensive medical history questionnaire to put free on the internet, as I just mentioned. And the other is to find people who would know how to develop a serial television program to depict what good parenting looks like, what supportive parenting looks like, contrasting that with unsupportive parenting. In other words, not to teach parenting by conventional didactic methods of lectures or books, but by depiction, by theater, actually, by storytelling.
Thank you.
I think those would both be huge advances.
Another quick question we had was, how do we expand this knowledge within the field of education? Childhood experiences such as trauma definitely influence how a child learns.
Okay, so here's the thought. If you can get a local newspaper, could be a student newspaper, could be a community newspaper, to publish the one-page version of the ACE study questionnaire, 10 questions, and ask readers to respond anonymously, then pool the anonymous data and publish it. Where that has been done, it has attracted community interest overnight. I mean, really extraordinary. So if you want to develop community interest in this subject, that's a very good approach to keep in mind. in a school system, the use of theater. Hey, you guys ever written a play before? No? Well, let's learn how to write a play today. Let's write a play about a kid who's growing up in a house where somebody's getting hurt. Where's the house, in town or out in the country? And who lives in the house? What are their names? And what are they like? And what's happening in the house? Okay, to do this as a group. Hey, I'm not talking about me. I mean, this is make believe, but obviously we have to use our own life experiences to know what to feed into a make believe system. So that's another technique that can be used. In our obesity program, for instance, we found that it was remarkably beneficial to carry that program out in small, stable groups, so that the basic program, the core program, was 26 weeks long, weekly meeting, 2 hours a week of the same 12 to 15 patients. And we would not teach them things, we would ask them questions to help them discover what they knew within themselves and bring it up into consciousness. Asking questions at the beginning like, why do you think people get fat, etc. And then progressing to questions like, are there any benefits to being fat? And what people would begin to say was really quite remarkable. Somebody would put out something small, somebody else would, well, all right, so I can say my piece and I'll put that in. And pretty soon you have people integrating within the room. So they end up providing themselves a support system, which often makes up for a support system that doesn't exist at home. So those are useful tools to keep in mind.
I'm going to shift gears. I know there's more questions coming in the Q&A, but I have a list also in front of me from
Right.
folks who chimed in. Unless Tony, you want to add to that?
Oh, am I frozen? I think I am.
No, we see you and hear you.
Shoot. I think I'm in trouble with my internet. Lisa, can you hear me?
Yes.
Okay. I saw a question there that someone asked in the chat about what is needed. What else is needed for physicians and folks screening for ACEs? What kind of training, knowledge, skill set? And I just wanted to say out loud that I think one important thing for anyone who is going to take the information of ACEs and use it in some way in their practice or in their profession, whether as an educator or a physician or a therapist, is really understanding implicit bias and the issues of equity and justice and diversity and race.
Yeah.
I think those are extremely important because, as you know, and that people, when they talk about or train on ACEs, needing to really go back to the original study, as Dr. Felitti said, that is, you know, predominantly that was the majority of those studied were Caucasian, highly, you know, educated, college educated persons having that number of ACEs. And that when we work in public service, when we work in public mental health, when we work with populations of color, we often assume that that are somehow related to that group or that circumstance, but really needing to understand implicit bias, race, justice, and race and social equity issues.
Yeah, well, in that vein, it's important to keep in mind that the 10 ACE questions that we used are not the only 10 in the world. I mean, if we had a population that had a lot of people just getting off the boat from some war-torn corner of the earth, or, you know, living on the street, et cetera, there would be other additional questions. So something to keep in mind is if you use the 10-page, the 1-page 10-question questionnaire, you might add question 11. Is there any question that should be added to the above? And see what your own population thinks about that.
Thank you so much. I know we're running out of time and maybe have time for one more question. And there's just, I'm trying to go through, there's a lot coming up right now. One had, for ACEs score, it includes violence against mothers. is there any data or evidence against fathers or against parents in general? So that was just.
There is, but we did not study it because that was just such a small piece. I mean, we simply arbitrarily took the 10 most common issues. You know, we didn't pick the 11th or the 17th or the 23rd, just the 10. And, you know, we obviously learned a hell of a lot by doing that. Keep in mind that when we're going to begin speaking about the unspeakable, keep in mind the idea that we developed. I see on the questionnaire that. Can you tell me how that's affected you later in your life? That makes it a lot more comfortable if you collect the information with an inert mechanism initially, and then ask the patient how they think that that has affected them.
Thank you. I have one question on the list, and it's very general, but maybe can lead to more conversation. Is it ever too late to address ACEs in childhood trauma? I know it's kind of I know the answer itself, but I want you to give a chance to close with that.
The answer is no, but it becomes progressively more difficult as you know, decades go by.
Mm-hmm. Right. Thank you for that. It was just one of the questions in the registration that I thought was interesting. Yeah. I know we're on my clock, it says 12 o'clock. I'll be mindful of everyone's time, but definitely want Tony or Dr. Felitti to any wrapping or closing remarks, because I know a lot of people have to jump off at this time.
Dr. Felitti, do you have any closing remarks or?
Well, I think my main one is that I hope that in your audience, there will be people who decide to start putting this information into play and further develop what we know about how best to do it, how it can be done on a large scale, productively, etc.
Yeah, thank you. And Lisa, I think I'm going to toss my closing remarks to you, because I think now that we've had Dr. Felitti's presentation, I'd like to toss it to you a little bit to talk about the ACEs Aware initiative grant that we have received, what we're doing with that, but then also just community-wide, what people can reach out to you for in terms of ongoing training and support.
Yes, thank you so much. So thank you, Tony. Thank you, Dr. Felitti, for your time. Great presentation. I always enjoy listening to you speak as well. So as Tony mentioned, Tri-City is a recipient of the ACEs Aware Initiative grant. We receive funding to provide supplemental trainings to educate all our community partners, service providers, medical providers within our area on ACEs. What is ACEs, the impact of toxic stress and trauma, and how to start having conversations, healthy conversations around the impact it has in our lives, and then also the ripple effect, just like the question of, you know, my trauma, am I passing that down to the next generation, and how do I stop that cycle of toxic stress or an environment of toxic stress? So please, at the end, you will be getting a follow-up email for those of you who registered and attended, with an email link with where you can contact myself and Tri-City. We will be providing free community trainings, supplemental trainings on ACEs Aware. Again, this is in partnership with the grant we received for the ACEs Aware initiative. We also are looking to strengthen our partners with medical providers, service providers, behavioral health providers in our area, just so we can start having these conversations and get the training. I know a lot of folks have asked in an educational setting, in a medical office, in my community, how do we have the conversations and how do we start addressing this? And through our trainings and presentations, we hope that this is something that we can start doing more in our communities. And I really want to thank Dr. Felitti for his presentation. I feel his presentation really kind of launched us in the directions to, there's research, the study, the importance of it, and as a community, how can we all become ACEs aware and really support ourselves first and those that we know who are struggling because of toxic stress and trauma they were exposed to currently or in the past, and hopefully try to prevent it moving forward into the future. So thank you everyone for your time and energy for the presentation.
Thank you so much.
Mhm.
There was a last chat comment that came through right after I spoke, and it was from a person who's a peer support specialist. And I think she made a really great point that within her specialization, within that expertise of peer support specialist, she's actually able to engage and share with clients her own experiences around ACEs in a way that other disciplines and professions are not, and that really helps clients to come along. So I'm very excited that California now is working toward its peer support certification, and we'll be able to actually add that to the mix of our multidisciplinary teams across the state. So thank you, Jessica Hicks, for bringing that forward. Thank you, everyone. It was great to see you and hear from you.
Thank you very much, Dr. Felitti and Tony and Chris and everyone else who was on the back end supporting today's webinar. And for everyone who's been asking, yes, we did record this webinar, so we do have access to it. The slides, unfortunately, we don't have access to the slides, but we do have the PowerPoint recording, so you can definitely review that again.
At tricitymhs.org.
Yes.
And
we will be sending an email to everyone who came on, a link to our website once the recording is posted there. So we have your registration. That's why we asked for this information, because we know there's a lot of follow-up information and resources we want to share after today. So if you registered with your email address, you will be getting an email from us with the link, with the resources, and future upcoming trainings that we will be providing as well.
Great, thank you.
And I just want to share for those that are viewing on Facebook Live, you can actually reach out to us by direct message on our Facebook page, and we'd be happy to get back with you with that information as well.
Thanks, Chris.
Okay.
All right.
I think we're good.